I'll be talking about comparison of the various Octa machines and the economics associated with the machine. Octa is a non-invasive, rapid, in vivo cross-sectional image which tends to um, look at the dynamic microvasculature of the retina and the choroid. Although it's been there for almost 20 years now, but more importance has been there and it has garnered more wide acceptance in the past 8-9 years or so. Usually, the basic principle is it is similar to what we see in an ultrasonography. Ultrasonography uses sound, whereas Octa uses near infrared light, and it has two components. One is a kinetic component and a static component. So the moving RBCs and sequential photographs of that particular area against the normal non-moving surrounding structures like the retina, choroid, and the other vascular structures is seen, and then the machine interprets this image, and then it creates something like a network-like picture. So the the easiest simile which I can put forward is this video. If you look at it, it's a flip book which was commonly used for children. Now, if you just go through it again, you can see how multiple pictures of the same photograph, when repeated over a period of time, they tend to give you an illusion of motion, and that is what an Octa does. The various algorithms which are used, this is an exhaustive list. You do not need to really sit down and memorize any of these. It is just a basic physics and mathematical application of the thing which we utilize, and these are the names given to it. Then the other methods which it uses in order to amplify the images is speckle variation, variance, amplitude decorrelation, phase variance, a combination of both of these, and a probabilistic approach. So when I did not understand, I went back to the artificial intelligence. I asked it what exactly these meant, and it threw at me a multiple jargon of many things, which again confused me more. So what I did, I went back and just summarized it into 4 lines. So SD Octa, that is a spectral domain Octa, is a standard choice when we need a good resolution. SSADA is actually, if you go back, it's a split spectrum amplitude decorrelation angiography. This one enhances the image quality. When you have a swept source Octa, you have a better depth penetration, whereas a full field Octa gives you a wider field of imaging. The other parameters which are looked in are vessel density and the flow index. If you look at the difference between the A scans per second between the different machines, like a time domain OCT all the way till the Octa operates at somewhere more than 70,000 A scans per second, and the actual resolution which it provides is somewhere to the tune of 5 microns. So the image information which is acquired by the machine is dependent upon the shortest interval between two successive B scan images. So the shorter the distance, the higher is the resolution and the higher the sensitivity threshold. So if you look at the various machines available and only focus your attention towards this column here, Heidelberg has the minimum separation between two different B scans at the level of around 5.7 microns, and the highest is seen in the Canon machine, which is around 12.9 microns. So again, after taking these photographs, the software tends to average these photographs to give a clearer picture, which can be of two different types. Again, we cannot go into the details because it is going to be an exhaustive exercise for us. The only advantage of OCTA happens to be it is a non-invasive, a very rapid image acquisition technique, as opposed to an angiogram which takes around 10 to 15 minutes and an ICG angiogram which takes all the way till 30 minutes. This can be achieved in less than 5 minutes, taking something like about 6 seconds per image. Can be used in patients who are allergic to dyes, pregnant, or any other contraindications to the use of the dyes. And with the advent of the wide angle Octa, broader areas can be assessed, like in the newer machines like the Zeiss Plex Elite, which can give you sections as large as around 12 millimeter by 12 millimeter. The only limitations are that it is not a replacement, and I repeat, it is not a replacement for the dye-based angiography. Now, when we are used to seeing angiography, what we appreciate is the pattern of leak. Now, the problem is that when the movement of RBCs is slower than the resolution limit of the Octa machine, it does not register as a flow. That is why on Octa, microaneurysms do not show as a leak, or you do not see flow pattern on a microaneurysm, because the flow is very sluggish there. So where do Octa machines stand in the present day and age? It adds to our different multimodal imaging techniques like a fluorescein angiogram, ICG angiogram. You have autofluorescence, you have to it near infrared, confocal blue reflectance. All of this added together with Octa will give you a broader picture, and it brings into different parts of the diagnostic puzzle, having its own strengths and limitations, as we had already discussed. The various machines which are available are again the extensive list, but I have just brought it down to 3 major players right now in the market which are available in India. One is the Spectralis, Merante, and the Plex Elite. All of them are exorbitantly pricey. The only difference between them is the wavelength which they use and the different slabs which are used. So the only thing is you cannot interchangeably interpret a machine information taken from a Spectralis as what you would do for a Plex Elite, because the slab which is used in a in the Spectralis is segmented at a different level as what is in the other 2 machines. To improve the image quality, we need to have something like a projection artifact removal tool, averaging of images, and also AI-based correction of the single image. Final tips and suggestions: that you always have to double check the flow in the B scan. You have to see for the change in reflectivity and always move the slab up and down. Economics, the answer, always the big question: is it really for you? It depends on your area of practice and your subspecialty which you subserve. If you are in an institute, probably it is an indispensable tool for learning the new basics of the disease. The investment, is it worth it? And really, does it live to the hype? Yes, it does. But it does come with a pinch of salt. Thanking you. Now I'd like to invite Dr. Anubhav Goyal, and he'll be talking on interpretation and artifacts in Octa.
So thank you, KSOS, and thank you, team, to give me this opportunity. So my talk is on Octa OCT angiography and overview. So basically what my colleague has told, OCT is basically an additional instrumentation in our armamentarium. Good for institutes use, but for private practice it might be doubtful investigation modality. So there's a basic thing which we all use now in and out in OPD is OCT. It is non-invasive 2-dimensional imaging, whereas Octa is non-invasive 3-dimensional imaging. OCT don't detects motion images. It just takes 2D images and multiple B scans to show you 2D section, but it OCT detects motion detection, and it gives 3D image till the very deep layers of retina and choroid also. So this is what he has already told. Some part will be repeated, overlapping. So it's a non-invasive modality, employs motion contrast imaging for high resolution volumetric blood flow analysis, visualizes blood flow down to the capillary level in choroid also. The flow which is less or more than the usual flow what it detects will be difficult to visualize over it. So the flow has to be very in the limits of what the machine should recognize. It has to be a moderate flow. So with this Octa, since it's a non-invasive thing, you can diagnose and follow up and can repeat it on all the visits. It's easy to use and to see the pathology on repeated screenings. So pathogenesis, it's basically to study tissue volumetric analysis based on very small pixels, 5 micron resolution. So it is called as voxel. Instead of pixel, it's voxel. Volumetric analysis at the pixel level. And it repeat the images with the increased reflectivity with high decorrelation signals basically to give an image induced angiogram, the picture which is more with a very high resolution, much more than what we do in invasive angiography. So as OCT also takes multiple B scans for to give volumetric analysis, and from layer to layer it gives very good resolution of each at every capillary level. It's better than angiogram. Why? Because angiogram is an invasive technology and it takes longer time. It has a lot of side effects. It doesn't separate retinal layers and choroidal layers separately. But Octa, since it is a 3D resolution and it goes very deeper from the superficial layers, so it can show you very definite layer by layer. It can be repeated. Every follow-up you can use it to see the improvement or worsening of in the retina and choroid both. And it generates images of high contrast resolution at much better than fluorescent angiography and SCG, because patient who has allergy to these dyes can be used as a very important imaging technology. Though so these are imaging differences already discussed. So it give images just like a tissue retina choroid biopsy, like OCT, with a 3D resolution. On the left upper you can see the superficial plexus, left lower you can see the deep plexus. See the capillary level has started from the major to minor capillaries. Third one is zone of photoreceptors in the right upper side, which can very precisely show the photoreceptors. And the fourth one is choriocapillary layer. So these are the basic 4 segmentations, which gives you a broad idea at what level the pathology and imaging is lying. So along with black and white scanning, if you use color imaging, you can differentiate easily the depth of the lesion also on color imaging, because green is the superficial, red will be the deeper one. So these are commonly available OCTA machines in Indian market. SSOCT, as Dr. Jyoti has told, it is very good since the wavelength of light and used in this is 1050 nanometers. So it goes to very deeper penetration, but resolution is definitely more in spectral OCTA, Heidelberg OCTA. We are using Heidelberg OCTA, so I'll be showing images of that only. So since it has a resolution of nearly 5 to 7 microns, very deeper penetration, and the slab what it takes is 10 to 10 for high resolution you have to take 10 to 10 degrees. For wider field you have to take 30 to 15 degrees of field. Since Heidelberg has an eye tracking system, the chance of overlapping and image confusion is less. You will get a very good image because of eye tracking system in Heidelberg. So you can see left side is FFA and right side is OCTA with a wider slab and with a posterior smaller slab. On the extreme right you can see very fine capillaries, and the middle it is diffusely seen capillaries, and on left side, extreme left side, because of early angiogram it's difficult to see. So Octa will definitely show you very minor details of pathology at capillary level. So only thing is it has to be very carefully segmented, and the segmentation, once you are using the same machine, it can be automated. Since it's an automated technology, it can be repeated at the same level. If you are using different machines, yes, it's difficult to repeat the same thing at the same level, because every machine has a different wavelength of light to take. So this is the example I'm showing diabetic diabetic retinopathy. In this you can see enlarged foveal avascular zone, which is a sign of macular ischemia. Very faintly seen on angiogram, but on Octa it is very nicely seen on right side. You can see pathology at multiple capillary level. This is an example showing microaneurysms and hard exudate, which can be seen in the middle, third at the arrow level, microaneurysm at the end of these large capillaries. Though it is difficult to detect, but with careful imaging you can detect it. Fourth one is showing different levels. Yellow are the superficial layer where you can see vessels, green is the second layer, and red one is the deepest layer. So you can have an idea at what level the lesion is lying. This is the OCT of progression, how the diabetic retinopathy, showing how the diabetic retinopathy is progressing. You can see the CNP, capillary non-perfusion areas are increasing, which can be very nicely delineated on the Octa. This is the image in the left lower corner. Surface NV is seen. So NV, capillary abnormal capillary network, can be easily seen. This is a imaging technology which will read the flow signals. So whether it is pathological or physiological abnormal vessel, it will not delineate, but it will show you that. So in this, surface NV can be easily seen, but NV very raised over the surface is difficult to delineate because of the resolution and slab. Most common imaging pathology which we use Octa in our day-to-day is wet AMD, all know. So this is example showing a CNVM at the level of above the photoreceptor layers. This is a Medusa head pattern of CNVM. There are different pattern of CNVM you can predict. On the left side, CFAN, or right side Medusa head, and then lower network, and other thing. This is type 1 CNVM, in which you will see CNVM at the level below the RP. So this is example I'm showing. And in the third image, you're seeing CNVM above the photoreceptor layers, which is very characteristic of type 2 CNVM. I'll just rush. You can follow up the CNVM over the Octa. You can see recurrences. It can be used in REP, as you can see capillary network following between the retina and deeper layer of retina and choroid, which can be easily seen with the follow-up of capillaries in different layers of Octa. In Mactel, you can see telangiectatic vessels more clearly in through Octa. You can see in the second image in the middle the telangiectatic vessels in the superficial and deeper layers, and you can follow up the progression of Mactel in different grades through the Octa. You can see vascular occlusion, which my colleague will be covering later on. So limitation is it cannot detect leakage, pooling, staining. Octa misses very slow flow signals or very fast flow signals. Poor repeatability is there. Artifacts are there, which can make us difficult predicting Octa. This is a projection artifact for large floater hemorrhage, or a thick vessel over the retina can cause difficulty in visualizing lower images. Projection artifact, if there is anything on the superficial layer of retina or in the deep posterior vitreous cavity, it can project an image over it, as you are seeing water level on the lens. So this is an image. You can usually vessels are seen in the superficial slab. They are in this example, you can see these vessels seen in the third slab also, which is a projection artifact. Vessel should not be seen in deeper layer or photoreceptor layers. Motion artifact, you can see the breakage in the capillary continuity in the lower image, which is because of the horizontal eye movement. So in this image, you can see with the white lines, these are the significance of motion artifact, and you can see breakage in continuity seen by the arrow in this image, which can be rectified by repeating the Octa. Left side, this is an image of us again, same motion artifact where the image acquisition is bad, and with repeatability has improved. This is vessel doubling artifact. Segmentation artifacts are common when there is collapse, mostly in Mactel. So through a single slab, through a single level, if you divide the slab, it's difficult to differentiate which level from which level of retina it is going.
Wind up.
Yeah. So Octa can be used in glaucoma also. You can see differences. Thank you.
So that was Dr. Anubhav Goyal. Now I am inviting Dr. Basil. He will be talking about Octa in diabetic retinopathy and various retinal vascular diseases.
Good morning, everyone. Thank you, KSOS, for giving me an opportunity for this presentation. So today I'll be talking about OCTA and diabetic retinopathy and retinal vascular diseases. So basically, OCTA is not a diagnostic tool for diabetic retinopathy, but it helps in the supporting our diagnosis. So as you know, we have three vascular complexes. One is the superficial vascular complex, which is seen between the nerve fiber layer and the ganglion cell IPL layer. Then we have the intermediate complex, which is seen between the ganglion cell IPL layer and the outer and the inner plexiform layer, and the inner nuclear layer and the inner plexiform layer, and the deep vascular complex, which is seen between the inner nuclear layer and the outer plexiform layer. So OCTA is based on the ability to image flow in retinal and choroidal vasculature. So we have three patterns of abnormalities. One is the abnormal presence of the flow, and this is basically neovascularization, and which can be either in the retina or in the choroid. And this is actually a choroidal neovascularization, which will be dealt in the later talks. Then we have anomalous vessel geometry, that is, it can be either dilated tortuous vessels. And here you can see the most common condition is central retinal vein occlusion. And this is the patient with central retinal vein occlusion showing anomalous vessel geometry. And the next is absence of flow. Absence of flow can be either due to non-perfusion or capillary dropout. Here you can see an area of non-perfusion within which you find an area of abnormal blood flow. So this is a patient with peripheral vein occlusion with neovascularization, and which typically occurs at the junction of the perfused and the non-perfused vessel. Now, OCT in diabetic retinopathy, it's helpfocal because it might be seen even before we can see it clinically. For example, the increased foveal avascular zone, decreased parafoveal vascular density, and the lower foveal density at the deep capillary plexus. These indicate high risk of diabetic retinopathy. So in diabetic retinopathy, we look for macular ischemia as well as neovascularization. So this is a patient of showing the fundus fluorescein angiogram. Here you can see there is an increased foveal avascular zone. The same thing with OCTA is also picked up. You can see an increased foveal avascular zone along with the capillary dropout, which shows macular ischemia. This is another photo showing the foveal avascular zone, increased foveal avascular zone in fundus fluorescein angiography, and the same thing is seen in the OCT angiogram. And the microaneurysms which are seen in the fundus fluorescein angiography cannot be picked up in OCT angiography because OCT angiography doesn't show leakage, but only the blood cell movement within the capillaries. Now let's see few case examples. This was a case one, a patient who came to the OPD with vision of 6/9 in both the eyes. It was a mild non-proliferative diabetic retinopathy. And as you can see in the OCT thickness, there is no significant macular thickening. But the OCTA shows increased foveal avascular zone, not only in the superficial capillary plexus, but also in the deep capillary plexus. So the macular ischemia was responsible for the subnormal vision in this patient. Now, this is another patient which was diagnosed as severe NPDR, but the OCT angiography over the disc shows neovascularization, and hence the diagnosis changed from severe NPDR to PDR. Now, this was another patient, a one-eyed patient with a right eye vitreous hemorrhage, and the left eye showed moderate NPDR. And this is a montage picture. But the OCT angiography shows peripheral capillary dropout along with the neovascularization from the disc. So the diagnosis changed from moderate NPDR to proliferative diabetic retinopathy. So nowadays in the market there is wide field OCT angiography, which is about 16 by 16 millimeter, in which with a single shot of OCT angiogram we get the peripheral capillary dropouts, and even the peripheral neovascularization could be seen. Now coming on to retinal vascular disorders, OCTA is an excellent tool for imaging areas of ischemia and the non-perfusion. It also helps in detection of neovascularization. And the ability to image the deep capillary plexus is one advantage of OCTA over fundus fluorescein angiography. Now this is a patient with central retinal artery occlusion, and the fundus angiogram and the fluorescein angiogram shows the macular ischemia, and the same thing is picked up in OCTA. There's another patient with branch retinal arterial occlusion, and as you can see here, there is a hyperreflective lesion in the OCT in the superior macula. And the same thing when you look at the superficial capillary plexus, you can see there is a hypofluorescence. There is a hypoperfusion in this area in the superficial capillary plexus, and also in the deep capillary plexus, you can see there is a hypoperfusion. So all these can be picked up in OCT angiography. This is the picture of branch retinal vein occlusion. This is the fundus photo, and the fluorescein angiogram you can show peripheral capillary dropouts, and the same thing is picked up in the OCT angiography. So it is an advantage. The OCT angiogram is an advantage of compared to the fundus fluorescein angiography, because we can see almost the same picture. Now this is a montage picture in which it was a lasered branch retinal vein occlusion, and the capillary dropout areas can be seen in OCTA. Now this is a picture of peripheral vascular lesion in which the capillary dropout areas are seen in the superficial vascular complex. But if you see in the deep vascular complex, it is seen much more. So what we see as the perfused, whatever remains perfused in superficial vascular plexus will not be perfused in deep vascular plexus. So basically we have to look not only the superficial vascular plexus but also in the deep vascular plexus, because over there we can see much more changes. Now this is a OCT angiogram of a patient which has come for subsequent follow-up. Here you can see this was a fresh branch retinal vein occlusion. Here you can see the OCT is same for both the eyes. There was not much of a macular thickness, but on subsequent follow-up of this patient, you can see there was development of collaterals in subsequent visit. So this was showing a compensatory vein occlusion. Now in case of non-ischemic CRVO, here you can see there is a macular ischemia with capillary dropouts in the superficial as well as in the deep capillary plexus. So hence OCTA is helpful in diagnosing both in diabetic retinopathy and retinal vascular diseases. Thank you.
Thank you, Dr. Basil. You were right on time. And now I'd like to invite Dr. Rahul Menon for his talk on OCTA in AMD.
So, a very good morning to one and all. I'll be talking to you about OCT in AMD. So, OCT is a non-invasive imaging technique. Now, before compared to before, it has become a very routine practice in our day. Like every case of AMD, I would prefer to look at that OCT picture. Now, how does the CNVM look on OCTA? So, there are 4 patterns of CNVM. One, C-fan pattern. Second, Medusa head appearance. Third is the ill-defined pattern, and the fourth is dead tree pattern. So the C-fan pattern is when 90% of the membrane appears from one side of the lesion. Okay, and you can see the multiple capillaries and all this anastomosis on one side of the major vessel. The Medusa head appearance, just like the name, you will have a central vessel and the vessels radiating in all the direction from that side, and you will see the perilesional halo and everything, which I'll be coming across later. So the vessels will branch in all direction from the center of the lesion. Then you have the ill-defined, just like the name, it lacks a distinct membrane morphology. And then you have the dead tree pattern. So then the dead tree pattern, you have long dilated filamentous vessels with, you won't see much capillaries or branching over here. Now, of all the 3 patterns that I mentioned, the C-fan pattern, the Medusa head appearance, and the ill-defined, all these 3 are active lesions, whereas the dead tree pattern, it indicates chronicity. That is, there's no exudation there, so you don't have to go and treat such cases. So, how do we define activity in a case of CNVM from OCTA? So, whenever we talk about OCTA, there are 2 images that we are supposed to look at. One is the emphase image. We are mostly concerned with the emphase image. We go on the face value. There's also something called as cross-sectional OCT. So in the emphase OCT, you look at the branching pattern. So if you see over here, you can see multiple tiny capillaries over here. They will usually have a well-defined shape with tortuous lacy vessels. And in anastomosis, you will see multiple anastomosis and loops over here. Now, you also see this is the most important thing which I look in my OCTA in case of CNVM, that is the perilesional halo. Now, this perilesional halo is seen in the ORCC slab or the choriocapillary slab. So if you look at this image over here, you can see the CNVM here, and surrounding it is a dark lesion. Okay, you don't see much vessels or anything over here. This is the perilesional halo, and it indicates activity. Now, why do we see it as a dark region? There are multiple theories. One is because even if you see, if you look at the early images of ICG images of CNVM, you will see this halo. So what happens is most of the blood is sequestered within the CNVM complex. So you don't see much, there's not much blood flow happening over there, and that is the reason you see this halo. Or there could also be another possibility that there's a much very turbulent blood flow around the CNVM, and that is the reason it's not picked up in OCTA. So you always have to look for this halo. If you see this halo, keep an activity, be suspicious that the CNVM is active. Next is the cross-sectional OCT. So what happens is, like I said, we always go on the face value. We just look at the emphase images. Make sure that you also look at the cross-sectional OCT. What happens is, all these OCTs, there's something called as flow analysis. So you look at the emphase image, you can see a good CNVM complex, and on the cross flow analysis, you can see the blood flow there. So that actually indicates there's a blood flow. So it means that this lesion is active. Now, it is not just you cannot just pick up type 1 and type 2 CNVM. You can also diagnose type 3 CNVMs with OCTA. Now, if you look at, I don't have to go into the slabs, which I hope Dr. Jyoti has already taken over. So this is the superficial plexus, this is the deep plexus, and this is the avascular segment. In the superficial plexus, you can see the circled region, you can see the CNVM network over here, you can see it in the deep plexus, and you can see also in the avascular slab. So this is the emphase image. Now, if you look at the cross-sectional OCT, you can see the flow through the entire retina. So that means this is you're dealing with a case of type 3 CNVM. This is another image of type 2 CNVM. You can see the deep plexus in the deep capillary plexus. You can see the CNVM network, and in the OCTA, in the cross-sectional OCT, you can see the flow in the entire segment of the retina. So, what happens with with the CNVM in OCT with treatment? So, this is an image of OCT NFAS image, and you can see the structural OCT where you can see the CNVM network. Now, after injection, what happens is the anastomosis and loops, they reduce. The number of capillaries that you see, they kind of shrink down. Okay, the size of the lesion is almost the same. After that, the size of the lesion starts reducing, and finally, what happens is the entire immature membranes kind of get kicked out, and you only have you're left with the mature membranes, mature vessels, and that is how you see a scar tissue happening over there. So, our purpose in this instruction course is like basically once you go back to your clinic, you should be able to see how to go about reading an OCTA. So I always prefer, like, it is not just imperative you look at the NFAS value, NFAS image and the cross-sectional OCT. You should also look at the structural OCT. It has a very paramount importance. So this structural OCT shows a fibrovascular PED. It's a case of basically a CNVM. Now, you first look at the superficial plexus. Now, in the superficial plexus looks very much apparently normal. Now, the deep plexus, you can see some kind of activity happening over here. Now, this could be either a type 2 CNVM or probably, it might be a projection artifact. Then you look at the avascular slab, you will see a well-formed membrane over here. And in the choriocapillaris slab, you can see the CNVM over here with the perilesional halo. So that's how you go about a case. So you see the structures OCT, you get the NFAS image, and you go through each segment. And then finally, to top it all, you have to go look at the flow analysis. So in this, we were little doubtful whether it's a type of whether it's a type 3 CNVM or a normal type 1 type of CNVM. So you look at the cross-section flow analysis, you'll see most of this blood flow is within the RP, below the RP, and there's hardly any blood flow above the RP. So this is a basically case of typical macular neovascularization and not a type 3 RAP. So whenever you look at all this, OCT images, you should be cautious, because now if I look at this NFAS image, I'm very sure most of us will say, oh, there's a very beautiful looking CNVM over here. But if you compare it with the structural OCT, what you'll realize is this region where you see the network, there's hardly any RP. The RP has been completely denuded over there. So that is why what happens is increased amount of light transmission happens, and you see picked up much more signals. So what you're seeing as a CNVM over here, this is not CNVM. Basically, it's the choroidal vessels. Also, in this image, you'll see, if you look at the NFAS image, you will see some kind of a membrane forming over here. And in the choriocapillaris segment, this is a vascular slab. Okay, and if you look at the choriocapillaris slab, you can see something like a perilesional halo. But if you compare it with what segment the scan was taken, you'll realize that basically there's a drusen over here. There's no activity. And what you're seeing in the blood vessels is basically projection artifact, and the halo that you're seeing over here is the shadow because of the drusen. So my take-home message is, can OCT replace FFA? At this moment, it is debatable, but by probably the 60th or 70th drishti, we might be talking about FFA being obsolete. Look at the NFAS image and cross-sectional OCT. Always, don't just go on the face value. Always, it's a good thing compare it with structural OCTs and beware of artifacts. Thank you.
Thank you for completing on time. And now I call on the last speaker, Dr. Juhi Cherian. She'll be talking on Octa in CSCR.
Good morning, everyone. Thank you, KSOS, and thank you, sir, for this opportunity. So I'll be talking about OCT angiography in central serous retinopathy. So Octa is a very important diagnostic modality which has got specific indications in central serous retinopathy. So when a CNV happens with CSR, it can reduce visual acuity in long-standing cases. Although it is uncommon, the incidence is only 2 to 9%. The overlap in presentation between chronic CSCR and CNV can make the diagnosis very challenging. So why Octa? Octa is a 3D non-invasive imaging modality which helps in visualization of retinal and choroidal vasculature as we were hearing till now. It helps to evaluate the choriocapiillary perfusion and the extension of flow voids. It helps in detecting CNV much evidently than a fluorescein angiography. Why? Because fluorescein angiography will have already existing features from the primary diagnosis of CSCR. So over that, finding out a CNV is a bit challenging. So this is an article from JAMA Ophthalmology in 2015 where they assess the association of CNV with CSCR using an Octa. So their major objective was to evaluate the sensitivity of Octa in detecting CNV associated with CSCR. They found very high sensitivity with Octa of about 100%, and in fluorescein angiography it was about 80%. And the reason that they have documented is one, that CNV in CSCR, there are fine vessels below the RP, between the RP and the Brooks membrane, which can be picked up in an Octa, which is not usually picked up in a fluorescein angiography. So when do we consider doing an Octa in a case of CSCR? CSCR patients who present above the age of 50 years. Frequent recurrent disease. In frequent recurrent disease, the persisting subretinal fluid might be because of the underlying CNV. Bilateral peripapillary disease. Many a times, peripapillary disease, clinically it presents as neurosensory detachment, but there might be an underlying PCN which is missed. And there are specific OCT biomarkers which will tell us to do an Octa in CSR, which I'll be dealing. So this is my first case, which is a 60-year-old female who presented with left eye blurring of vision and metamorphopsia for 2 years. Vision was 6/9 in left eye. As you can see, there's a neurosensory detachment with subretinal precipitates. An OCT done through the fovea, you can see there is subretinal fluid. There is a PED, but it is a flat, irregular fibrovascular PED. Apart from what we usually see in a CSR case, it is not a serous PED. And you can also see that there are Pachy vessels just in the subfoveal region. We performed an ICGA, which in the early sections show an abnormal vascular network. DFA done showed hyperfluorescence, which increasing in intensity in the later phases, showing a patchy hyperfluorescence. And Octa was done through this flat irregular PED, which clearly showed an active network as described earlier by Sir. So what is the importance of a flat irregular PED in CSAR? So this is an article published in Retina where they evaluated flat irregular PEDs in CSCR, and they found that 1/3 of these PEDs in chronic CSCR contain CNVM. So it is a very important biomarker which alerts us to go ahead and look for a CNVM. This is another article published in AJO where they assessed shallow irregular PEDs in pachychoroid spectrum disease. They compared dye angiography and Octa in finding out CNV, and they found that dye angiography many a times underestimates the presence of a neovascularization. In the study, neovascularization was found only in 29% cases of dye angiography and 95% cases where their Octa was performed. This is another case of a 68-year-old male who presented with right eye blurring of vision at that point of 3 weeks duration. First, he was monitored, medically managed, and he had good resolution in 2 months. Again, in the same eye, patient presented with a recurrence 1 year later. That time, you can also see some RP irregularities and a subretinal fluid. That time, an Octa was done, but there was no clear network. So that point, considering a chronic CSCR, a half-fluence PDT was done. Patient had good resolution, good improvement of vision. He remained stable for 2 years. After 2 years, in the same eye, patient again had a recurrence, but this time a change in OCT features are seen. There is a flat irregular PD with a hyper under it. When a hyper under a PD happens, you have to be suspicious of a CNV. So at this point, Octa was done, a network was seen. So this is an active network as described in the previous presentation. So considering CNV, we treated the patient with aflibercept, good resolution was seen, and a dead tree network is seen in the Octa, which was done after the aflibercept injection. So what is the importance of this particular case? It emphasized the need for serial evaluation and role of Octa in elderly patients with CSCR. This patient might have converted from a CSR, acute CSR, over the years to a PCN. So if it was not followed up, then we would have missed it, and the role of Octa as a follow-up tool. So this is the last case of a 54-year-old doctor who presented with right eye defective vision, not on any steroids. Right eye had 6/24 and 24 vision. You can see the neurosensory detachment with some yellowish material in the foveal region. This was the OCT done, which showed a pachychoroid. Subretinal fluid is there, subretinal hyperreflective material with irregular RP is seen. We performed an Octa at this point. A very suspicious network was seen, but there were no flow signals. So patient, we went ahead with ICG and DFA, and DFA showed a clear leak. Diagnosed as a fibrin CSR, performed micropulse at the leak, and eplerenone was given for a month. 1 month later, this was a picture, there was no much change. So at that point, we just repeated the Octa. The network showed a slight increase. Considering the increase in network, we gave 1 injection Accentrix. There was good resolution of subretinal fluid, but the fibrin remained. As we know, fibrin will take a long time to resolve, but he had good visual improvement, and this is the Octa pre and post injection, which showed good resolution of the network. This is the OCT image after 4 to 5 months, where we can see the fibrin has also reduced considerably, and the vision had improved to 6/9 and 6. So this is the message from this case, that when there is fibrin, there's a possibility that there is an underlying CNVM, so we have to look for it. So this is a case report, Octa findings in CMD, cystoid macular degeneration associated with central serous retinopathy. So in this report, they have documented that about 45% of eyes with cystoid macular degeneration, there was an underlying central serous chorioretinopathy. And this study, they evaluated the Octa findings in fellow eyes of patients presenting with CNV associated CSER, and 1/4 of fellow eyes showed vascular network. So it highlights the importance of imaging both eyes of chronic CSER for early detection of CNV using Octa. So to conclude, Octa helps in early detection and prompt treatment of neovascularization in CSER. FIPED is a very important diagnostic marker. This imaging modality is superior to other methods in terms of non-invasibility, reliability, and quickness. Thank you.
Thank you, Dr. Juhi, for an excellent presentation. And now we are open for questions from the house. Till we get questions, I'd just like to summarize the entire talk we had today. We have just tried to bring to the fore that Octa as an imaging modality can be used as an adjunct to our existing armamentarium for better understanding, better follow-up of patients in various diseases like diabetic retinopathy, ARMD, PCV, and more importantly, as the last speaker had already spoken about, CSR with PCN. As pachychoroid spectrum is on the upswing, we are now recognizing more and more of cases which have a pachychoroid pattern of disease. Following up cases of chronic CSR over a period of time with Octa tends to give us better insight into the occurrence of a sinister looking lesion below the CSR, and it can be treated in due course of time. Other than that, rather than looking it as a potential source of some other extra information, it is going to help us reiterate the fact that what we miss out on others, this may help us pick up early. Anything else you'd like to put up, Dr. Rahul? Anything?
Well, I'll stick to my topic. So in AMD, see, in treatment naive cases, to pick up and diagnose these cases is very simple. But what happens, when you start treating it, see, many of the times, it's not like the first time your patient comes to you. Many times the patient would have been treated with few injections elsewhere, and they come after you after 3 years or probably 2 years down the line. And that's when it makes much more, interesting. So then to pick up, CNVM on OCTA is little difficult. And not just pick up, but to whether define its activity. So such cases, that is where, FFA dye-based angiography still has a role to play. But, and then there is always the issue of artifacts and, especially if the patient has, all these patients are usually in the elderly population and they have a significant amount of cataract too. So, probably in a few years' time, with the technology advancing at such a great pace, probably we might come at a time when we can, get around the artifacts, or probably, even with denser cataracts, we might get a clear picture. In such situations, probably, that's what I said, probably in few years' time, I'm looking forward to a day when, dye-based angiography might probably very obsolete. And one more thing, I don't do a dye-based angiography for all the patients. I try to keep it with OCTA. But in some cases, when I start the treatment and I'm not very happy with the results, then that is the only time when I actually switch to going for an angiography, a dye-based angiography. I think that kind of summarizes up from my side.
Just to bring one more point of interest, it is called a silent type 1 CNVM. That is a new entity which was recently diagnosed. And in such a condition, in cases of CSR which do not respond well to treatment or show a progressive decline over a period of time, if you do an Octa, you are going to see a network at multiple points of time. And when we do a dye-based angiography, be it a fluorescein angiography or an ICG angiography, they fail to show any leakage in such a case. In this situation, it is called a silent type CNV, and it is advisable not to treat at this point of time until and unless there are signs of activity on an angiogram. So these are to be observed over a period of time, and this is also at times labeled as a non-exudative network on Octa, which should be treated only with caution. You do not need to go all gung-ho. Just because you see a network, you have to inject. It is not like that. Any questions from the house?
No, it was an elderly age group. Patient was about 68 years and a fibrin CSR. When a fibrin is seen at that age group, better to rule out an underlying CNV.
So I'd just like to add one point. Whenever in a case of CSR, we see a SHREM, that is a subretinal hyperreflective material, always have the, be suspicious of CNV, underlying CNVM there. Because see, what happens is OCTA has the biggest role in, picking up, it has one advantage over FFA is most of these chronic CSR cases, when we get an angiography, FFA, there is always an element of sick RP, a generalized sick RP. So you get multiple leaks and, you are not able to pinpoint whether there's an active CNVM there. That is where OCT scores over dye-based angiography. And whenever you see a fibrin or SHREM in the OCT, always have, these patients are mostly going to develop a CNVM. So OCT definitely is mandatory, I feel, in such cases.
I think Octa makes sense in following up patients with CSR and typically chronic CSR. As you've asked, Octa, we usually do follow up almost all of our patients with Octa. You don't know which patient is going to land up with a PCN or an underlying neovascularization, but the follow-up becomes very easy and the treatment becomes early on. We can pick it up and we can treat it accordingly rather than waiting for the inevitable to happen and then treat it. In myopic, actually, FFA is till now is actually the investigation of choice, actually, because OCT will not be able to pick up very clearly. OCT may show something like a SHREM or an irregularity in the membranes itself. You won't be able to pick up the features of a CNVM as aptly as you do in a normal age-related macular degeneration. In such a case, what we have done over the years is like we keep doing angiograms when in doubt. Octa exactly.
Slab is very difficult because of especially in myopic CNVMs, what happens is the contour of the eye is not very great. So to get an exact slab, it's very difficult. One. Second thing, you have some amount of RP disturbance over there. So you will tend to overdiagnose CNVMs in such cases. And also there are a few series where they have actually found out that dye-based angiography, like OCTA, kind of underdetects myopic CNVM. And because many of the times, even we just on the basis of a hemorrhage at the myopic, it could be something else. It would be phosphofuchsmin.
I think that sums it up for all of us. Thank you for attending the session. And thank you all the speakers. Thank you. I think we are finished in time.